Something is happening inside your body right now, tonight. Between 2 and 4 in the morning, not eventually. Not if things go wrong. Right now, on a schedule your body has run every night since you were born. During that 2-hour window, your pituitary gland releases the highest pulse of human growth hormone your body produces in a 24-hour period. Your stem cells, the repair workforce embedded in your bone marrow, your gut lining, your muscle, your brain, are supposed to be at peak activity during that window, dividing, differentiating, replacing damaged tissue, running the maintenance cycle that determines how fast or how slowly you age at the cellular level. Here's the problem. After 60, for the majority of people living with chronic stress, cortisol doesn't drop far enough at night to let that repair window open properly. The hormone that's supposed to be at its daily minimum between midnight and 40 m is instead sitting at levels that suppress the exact biological processes your body needs to run its repair shift. And most people have no idea this is happening. They sleep, they wake up, they choke up the fatigue, the slower recovery, the accumulating wear to getting older. But the mechanism is specific, it's measurable, and it's addressable. I'm Dr. Becker. Today, I want to walk you through what I think is the most underappreciated driver of accelerated aging in people over 50. Not what you eat, not what you're exposed to in the environment, but a hormone your own body produces quietly in the wrong pattern while you sleep. And then I want to show you what the research says about a specific intervention that has been studied in over 20 randomized controlled trials with a 60-day cortisol reduction in one landmark study of 27.9%. Before I go further, I need to be clear about something. This video involves discussion of hormones, adrenal function, and cellular aging topics that overlap with medical conditions including Cushing syndrome, hypothyroidism, autoimmune disease, and others. Everything I'm sharing today is educational, based on peer-reviewed research, and intended to give you a framework for understanding your own biology more clearly. It is not a diagnosis, and it is not a treatment plan. If you're currently under medical care for any endocrine condition, thyroid disorder, or immune disease, or if you're taking immunosuppressants, sedatives, or thyroid medication, please bring this information to your physician before making any changes. That's not a formality. There are specific interactions that matter for this particular supplement, and I'll cover them in detail when we get to the protocol. Now, let me tell you how I started thinking about this differently. For years, the conversation around cortisol in medicine has been dominated by two endpoints. On one extreme, Cushing syndrome, a clinical disorder of severely elevated cortisol caused by tumors or prolonged steroid use with dramatic physical signs and serious consequences. On the other extreme, Addison's disease, dangerously low cortisol from adrenal insufficiency. The vast middle ground where the majority of adults over 60 are actually living. Cortisol that's chronically elevated but not at disease levels. Disrupted in its daily rhythm, too high at night and too blunted in its morning peak. This zone has been largely ignored as a clinical target. It doesn't show up as an abnormal result on most standard blood panels. It doesn't produce dramatic symptoms. It produces the kind of changes we tend to accept as normal aging. Persistent abdominal weight gain. Fatigue that doesn't respond to sleep. Memory that's slightly worse than it was 5 years ago. A recovery time from illness or injury that's noticeably longer than it used to be. What the research has been clarifying over the last decade is that this middle ground, what some researchers now call functional hypercortisolemia, has direct measurable consequences for stem cell populations. And once you understand the mechanism, the urgency becomes clear. Let me walk you through what cortisol does to stem cells when it stays elevated longer than it's supposed to. Your body contains multiple populations of stem cells, and for the purposes of this conversation, the most relevant are your minimal stem cells, the MSCs housed primarily in bone marrow. These are the cells responsible for regenerating bone, cartilage, muscle, tendon, and connective tissue. They are the structural repair crew. In a healthy 25-year-old, MSC populations are abundant and highly responsive. By the time someone reaches 60, those populations have already declined to roughly 30 to 40% of their peak levels. That decline is partly a natural consequence of aging, and it's why healing from orthopedic injuries takes longer at 60 than it did at 30. There is less repair capacity available. Cortisol speaks directly to these cells through glucocorticoid receptors embedded in their membranes. Every MSC has these receptors. When cortisol binds to them, which is appropriate in short bursts during actual stress, when the body needs to mobilize energy and suppress non-emergency processes, the MSSE essentially receives a signal to stand down. Don't divide, don't differentiate, conservation mode. The immune response gets suppressed. Inflammatory cytokines get dialed back and the cell holds in place, rather than committing to active repair work. This is a perfectly functional short-term mechanism. It's the reason people on high-dose corticosteroids after surgery don't mount aggressive inflammatory responses. The glucocorticoid signal is systematically suppressing immune and repair activity to allow recovery. The problem arises when the signal doesn't turn off. When cortisol is chronically elevated day after day, week after week, year after year, the MSCs receive a continuous stand-down signal. They stop dividing at normal rates. The pool of available stem cells for tissue maintenance shrinks. And in someone who is already at 30 to 40% of their youthful MSE reserve, that additional suppression is not a minor inconvenience. It's the difference between a body that can still repair itself adequately and one that cannot. The molecular mechanism goes deeper than the receptor binding. Cortisol binding to glucocorticoid receptors suppresses the transcription of pluripotency factors, the genes that determine a stem cell's ability to differentiate into multiple cell types. The key factors are OCT2 and NANOG. These are not obscure proteins. They are among the most fundamental regulators of stem cell identity. When their expression is suppressed by chronic glucocorticoid signaling, stem cells lose flexibility. They become less capable of responding to the body's repair signals, less able to differentiate into the specific cell types needed, and more likely to either remain dormant or shift over pathways that produce fat cells rather than bone or muscle, which helps explain the characteristic body composition changes in people with elevated cortisol over time. Think of it this way: your stem cells are sitting in their barracks, ready to be deployed. In a healthy situation, cortisol rises in the morning, mobilizes energy for the day, then falls through the afternoon and reaches its minimum around midnight, giving the repair crew a clear window to work. What's happening in chronic stress is that the commanding officer, cortisol, never fully stands down. The stem cells never fully receive the all-clear signal. They wait night after night, and the body's repair deficit accumulates silently. There's a second mechanism that compounds this picture, and it operates on a longer time scale, but with even more permanent consequences. Chronic stress and elevated cortisol accelerate telomere shortening. Telomeres are the protective caps on the ends of chromosomes. They shorten a little with every cell division, and when they become critically short, the cell either enters senescence and stops dividing entirely, or it undergoes apoptosis and dies. Telomere length is one of the most direct measures we have of biological age as distinct from chronological age. A meta-analysis published in the Proceedings of the National Academy of Sciences found that people with chronic psychological stress had telomere lengths corresponding to 9 to 17 additional years of biological aging compared to low-stress controls. 9 to 17 years, that's not a marginal effect. That's the difference between cells that behave like they belong in a 50-year-old body and cells that behave like they belong in a 67-year-old body in the same person, depending on their cortisol history. For stem cells specifically, telomere shortening is catastrophic rather than merely limiting. A stem cell with critically short telomeres cannot divide, which means it cannot produce new cells to replace aging tissue. The repair capacity doesn't just slow down, it stops. And because the damage is in the telomeres themselves, is cumulative and largely irreversible. Every year of chronic high cortisol is not just a bad year. It is a year that permanently compresses the remaining functional lifespan of your stem cells. The window for effective cellular repair narrows, and it doesn't widen again when the stress finally resolves. There's a fourth mechanism that I want to include because it connects the cortisol story to the gut, and the gut connection matters both for the completeness of the picture and because it creates a practical intervention point. Cortisol's effects are not limited to bone marrow and the brain. The gut epithelium, the single-cell thick lining of your intestinal wall, is maintained by some of the most actively dividing stem cells in the entire body. The intestinal crib stem cells identified by the marker LGR5 renew the entire gut lining every 4 to 5 days. They are the fastest cycling stem cells in adult tissue, and they are directly sensitive to cortisol levels. Chronic cortisol elevation increases intestinal permeability, the condition commonly called leaky gut, by disrupting the tight junction proteins that seal the gaps between epithelial cells. As those junctions loosen, bacterial lipopolysaccharides and other gut-derived inflammatory compounds cross into systemic circulation, triggering immune activation that feeds back into systemic inflammation. The intestinal crypt stem cells trying to repair a lining that is being continuously compromised by elevated cortisol work harder and deplete faster. And a faster depleting gut stem cell population means a gut lining that becomes progressively less capable of maintaining its barrier function, which adds yet another inflammatory input to the cortisol-driven loop. This gut mechanism also explains why people with chronically elevated cortisol tend to have digestive complaints, bloating, irregular bowel habits, food sensitivities that seem to develop in middle age that don't have obvious dietary explanations. The problem isn't entirely in the diet. It's in the hormonal environment that's degrading the gut's repair capacity. Lowering cortisol addresses this mechanism directly, and the restoration of gut barrier integrity that follows is one of the less discussed but clinically meaningful benefits of HPA axis normalization. Cortisol and sleep have a reciprocal relationship that, once dysregulated, tends to reinforce itself in a direction you don't want. And this is where I think the title of this video is worth unpacking with precision, because the claim deserves an honest biological explanation rather than a marketing gloss. In healthy adults, cortisol follows a precise daily rhythm. It peaks about 30 minutes after waking, the cortisol awakening response, which is what gives you the energy and alertness to start your day. It then declines gradually through the afternoon and reaches its minimum between midnight and 12 a.m. That minimum is critical because the 2 to 40 a.m. window is when growth hormone secretion peaks, and growth hormone is the primary hormonal signal driving stem cell activity during sleep. It tells MSCs to divide, tells muscle satellite cells to initiate repair, tells neural stem cells in the hippocampus to produce new neurons, a process called neurogenesis that supports memory consolidation and cognitive resilience. High cortisol at night doesn't just disrupt sleep quality. It directly competes with the growth hormone signal. Cortisol and growth hormone have opposing effects on many of the same target cells. When cortisol is elevated during the window that should belong to growth hormone, the repair cycle is muted. The night crew shows up, but the work orders have been cancelled. This is the biological reality behind the title of this video. Restoring the normal nocturnal cortisol minimum doesn't double your stem cells in some hyperbolic marketing sense. It restores the nighttime window in which your existing stem cells do the work they are designed to do. Work that has been systematically suppressed by cortisol that isn't dropping the way it should. How do you know if this is affecting you? There are 5 patterns that in people over 50 are highly suggestive of disrupted cortisol rhythm. None of these are diagnostic on their own. A physician evaluation and ideally a dural salivary cortisol test is needed for that. But they are signals worth paying attention to. And if 3 or more of them describe your current experience, this conversation is directly relevant to your biology. The first is waking between 2 and 4 in the morning without a clear reason. This is one of the most consistent symptoms of elevated nocturnal cortisol. The cortisol surge that should happen gradually before dawn, serving as a biological alarm clock, is happening too early and too aggressively, interrupting sleep in what should be the deepest and most restorative hours. People describe this as waking suddenly, sometimes with a racing heart or a low-level sense of anxiety, unable to fall back asleep for 30 minutes to an hour. This pattern, when it happens consistently, is not a sleep disorder in the conventional sense. It is an HPA axis rhythm problem. The second is persistent abdominal fat that doesn't respond proportionally to diet or exercise. Cortisol drives fat deposition specifically in visceral adipose tissue. The fat around your organs through mechanisms involving lipoprotein lipase and direct glucocorticoid signaling in adipocytes. People with chronically elevated cortisol carry weight in a pattern that is genuinely different from standard caloric excess, and it responds poorly to standard interventions. The third is memory that has been declining faster than you'd expect. Specifically, working memory and the ability to learn and retain new information. The hippocampus, the brain region most central to memory formation, is one of the most cortisol-sensitive structures in the entire nervous system. Chronically elevated cortisol shrinks hippocampal volume and suppresses the neurogenesis that maintains hippocampal function. Studies in populations with stress-related cortisol elevation consistently show measurable hippocampal volume reduction and corresponding memory impairment. The fourth is the tired but wired feeling. Exhausted enough to want to sleep but unable to actually fall asleep or stay in deep sleep. This is the hallmark of an HPA axis that has lost its normal rhythm. The hypothalamic pituitary adrenal axis, which governs cortisol production, operates on feedback loops that become desensitized with chronic activation. The result is a system that doesn't modulate cleanly, producing cortisol at times when it shouldn't and failing to produce it at appropriate times. The fifth is getting sick more often or taking significantly longer to recover when you do. Cortisol is immunosuppressive by design. That's useful in short bursts, harmful when chronic. The stem cells most directly involved in immune maintenance are hematopoietic stem cells, the HSCs in bone marrow that produce your white blood cells, your natural killer cells, and the cellular machinery of immune surveillance. Chronic cortisol suppression of HSC function accelerates what immunologists call immunosenescence, the age-related decline in immune function that makes older adults more vulnerable to infection and less capable of immune surveillance against early malignant cells. If 3 or more of those patterns describe your experience, your cortisol rhythm is worth investigating and worth addressing. Now, Let's turn to the evidence because this is where the conversation gets genuinely interesting. The research on ashwagandha, specifically the standardized root extract form known as KSM66, represents one of the most robust bodies of evidence for any adaptogenic compound in the medical literature. We are not talking about a handful of small studies with questionable methodology. We are talking about over 20 randomized controlled trials, including a 2025 systematic review and meta-analysis published in a peer-reviewed open-access journal that analyzed 7 RCTs on cortisol, specifically involving 488 participants total conducted through a rigorous PRISMA compliance search methodology across PubMed, Web of Science, Scopus, and the Cochrane database. The conclusion was a statistically significant reduction in serum cortisol with ashwagandha compared to placebo across those studies. The landmark individual trial is the Chandra study published in the Indian Journal of Psychological Medicine, a prospective randomized double-blind placebo-controlled design involving 64 adults with chronic stress run over 8 weeks. The dose was 300 mg of KSM66 twice daily, totaling 600 mg per day. The primary outcomes included serum cortisol, perceived stress using the validated PSS scale, and sleep quality. The result on cortisol, a 27.9% reduction versus placebo. That is not a marginal effect. In context, pharmaceutical interventions for stress-related cortisol elevation are relatively limited and carry significant side effect profiles. A 27.9% reduction in serum cortisol over 60 days from a well-tolerated botanical extract in a properly blinded and controlled trial is a clinically meaningful finding. Sleep quality improves significantly as well, which closes the loop on the nocturnal cortisol mechanism I described earlier. Lower cortisol during sleep restores the growth hormone window. The repair shift runs. This is the physiological basis of the claim in the title of this video stated precisely. 600 mg of ashwagandha KSM66 in the clinical evidence reduces the cortisol that was suppressing your nighttime stem cell activity, thereby restoring the biological conditions under which that repair activity can occur. A second study by Lyon colleagues adds a dimension that is particularly relevant for men between 40 and 70. This was a double-blind placebo-controlled crossover trial in men with overweight and mild fatigue in that age range. The intervention used a standardized ashwagandha extract at a dose providing 21 mg of ethanol glycoids daily over 8 weeks. The results showed an 18% increase in DS versus placebo and a 14.7% increase in testosterone versus placebo. Both findings were statistically significant with p-values below 0.1. DS is important in this context for a specific reason beyond testosterone. DHEA, dehydroepiandrosterone, is produced by the adrenal glands and serves as a precursor to both androgens and estrogens, but it also functions as a physiological antagonist to cortisol. When cortisol is chronically elevated, DS tends to decline. The adrenal glands prioritize cortisol production at the expense of DHEA production. This ratio, the cortisol to DHEA ratio, is one of the most reliable biological indicators of chronic stress burden and biological aging rate. Restoring DHS toward more youthful levels while simultaneously reducing cortisol shifts this ratio in the favorable direction, and the effects on stem cell function are direct. DHEA positively regulates MSE proliferation and has been shown in multiple studies to support bone marrow stem cell activity in aging populations. The most recent comprehensive review on this topic, published in the journal Biogerontology in 2025, synthesized the evidence specifically on ashwagandha's guroprotective, meaning aging protective mechanisms at the cellular level. The findings go beyond cortisol reduction. Muthanone, one of the active withanolites in the extract, activates heat shock proteins, molecular chaperones that prevent protein misfolding inside cells. Protein misfolding is a central feature of cellular aging and is directly relevant to stem cell dysfunction. When proteins in aging stem cells misfold, the cells either malfunction or are cleared by the immune system. Heat shock protein activation helps maintain cellular protein quality control, extending the functional lifespan of the cells. The same review documented CRP reductions of over 30% in adults with chronic stress alongside reductions in IL-6 and TNF-alpha. The same inflammatory markers associated with microplastic-driven inflammaging that we discussed in the previous video. What this tells us is that ashwagandha is not acting through a single narrow pathway. It is working on several of the intersecting loops simultaneously. Cortisol, inflammation, cellular protein quality control, which is the hallmark of a compound with genuine systemic relevance, rather than one that's solving a single problem. The review also described evidence for improved mitochondrial function in cells exposed to ashwagandha with analytes, specifically through pathways overlapping with CoQ10 metabolism. Mitochondria in stem cells are not just energy producers. They are signaling hubs that influence whether a stem cell remains quiescent or becomes activated, and whether it differentiates toward functional tissue or towards senescence. Mitochondrial dysfunction in aging stem cells is a well-established contributor to the decline in regenerative capacity And the evidence suggesting ashwagandha supports mitochondrial health adds another dimension to its relevance in this context. There is also documented evidence of neurogenesis promotion through BDNF brain-derived neurotrophic factor regulation. Neural stem cells in the hippocampus are particularly sensitive to the cortisol environment, as I mentioned in the context of memory decline. Ashwagandha's effect on BDNF expression suggests it is supporting the same hippocampal neural stem cells that chronic cortisol suppresses, closing a loop from the stress mechanism to the recovery mechanism in the same organ system. There is also a long-term safety study worth citing specifically because the audience for this channel tends to be thoughtful about what they're committing to over time, not just looking for a short-term fix. A 2025 study in phytotherapy research followed 191 adults taking standardized ashwagandha root extract for 12 consecutive months, monitoring hematological parameters, liver function, kidney function, and thyroid markers throughout. The conclusion: no clinically significant changes in any of those parameters. The adverse event rate of 9.4% was comparable to rates seen with placebo in comparable studies. 12 months of daily use, nearly 200 subjects with comprehensive monitoring. This is the evidence profile that distinguishes a supplement worth considering seriously from the vast majority of compounds in the market. Now, with that safety context established, I want to be equally explicit about who should not take ashwagandha without physician guidance. If you are pregnant or breastfeeding, ashwagandha is contraindicated. If you have an active autoimmune condition, rheumatoid arthritis, lupus, Hashimoto's, multiple sclerosis or similar, ashwagandha's immune-modulating properties can theoretically exacerbate autoimmune activity, and this needs to be discussed with your rheumatologist or treating physician before you start. If you take thyroid medication, the interaction is significant enough to require monitoring. Ashwagandha has been shown in studies to increase serum T4 levels, which can push someone on level or similar medications outside their therapeutic range. And if you take any sedative medication, benzoypines, sleep aids, certain antihistamines, the additive CNS depressant effects of ashwagandha mean you need medical oversight to use both safely. These are not hypothetical concerns included for legal formality. They are real interactions documented in the research, and they matter more for an older adult population managing multiple conditions and medications than they do for a 30-year-old with no pharmaceutical burden. With that clearly stated, let me walk you through the protocol I would discuss with a patient in this situation. A protocol built around restoring normal nocturnal cortisol rhythm and giving stem cells the conditions they need to do their repair work. Ashwagandha KSM 66 at 600 mg daily. The research supports either splitting this dose 300 mg with breakfast and 300 mg in the evening, or taking the full 600 mg approximately 1 hour before sleep, which may be particularly relevant for the nocturnal cortisol mechanism. Both dosing schedules have clinical support. The key qualifier on the form is important. Look specifically for KSM 66 sensorial or show them on the label. These are standardized extracts validated in the clinical trials. Generic ashwagandha products using whole herb powder or non-standardized extracts having consistent with analyte content and inconsistent clinical outcomes. The standardization is not marketing. It is the difference between a product that matches the trial evidence and one that doesn't. Expect 4 to 6 weeks before the cortisol effect is substantial. The mechanism modulating the HPA axis feedback sensitivity takes time. With analytes don't block cortisol production in the way a pharmaceutical would. They restore the responsiveness of the feedback regulation that tells the adrenal glands when to stand down. That's a more physiological, more sustainable effect, but it's not immediate. The second element of the protocol is magnesium glycinate at 300 to 400 mg taken approximately 1 hour before sleep. Magnesium is a co-actor for over 300 enzymatic reactions in the body, including many in the nervous system, that regulate the transition from sympathetic to parasympathetic dominance. In other words, from the alert high cortisol state to the rest and repair state. The glycinate form specifically is used here rather than other forms of magnesium, because it has superior absorption through the intestinal wall in older adults where magnesium uptake efficiency tends to decline. Beyond the autonomic regulation effect, glycine, the amino acid component of the glycinate molecule, is a direct precursor to glutathione, the master intracellular antioxidant. Supporting glutathione production circles back to the oxidative stress mechanism that threatens stem cell DNA integrity, which means magnesium glycinate is doing double work in this context. Most adults over 60 are functionally deficient in magnesium even with reasonable dietary intake because absorption declines with age, and because common medications, proton pump inhibitors, diuretics, certain antihypertensives further impair magnesium status. At 3 to 400 mg of the glycinate form taken at bedtime, you're typically well within the safe range. But if you're on diuretics or have kidney disease, Have your physician check your magnesium and potassium levels before adding supplemental magnesium. The third element is phosphatidylserine 100 to 300 mg daily. Phosphatidylserine is a phospholipid that's concentrated in neuronal cell membranes, and its role in cortisol regulation is specific and well documented. It blunts the cortisol response to acute stressors without eliminating cortisol's normal function. Multiple randomized controlled trials in adults over 50 have shown that phosphatidylserine supplementation reduces the peak cortisol spike in response to exercise and psychological stress, with particular benefit for people who are engaging in moderate physical activity. It's well tolerated without significant drug interactions in the research to date, and it's an area where the mechanism is genuinely understood rather than speculative. Beyond supplements, there are behavioral interventions that the evidence supports as direct modulators of nocturnal cortisol. And I want to be specific about them rather than vague, because the specificity is what makes the difference. Diaphragmatic breathing practiced in the evening, specifically the 478 pattern, where you inhale for 4 counts, hold for 7, and exhale for 8, activates the vagus nerve through respiratory rhythm modulation. The vagus nerve is the primary parasympathetic pathway, and stimulating it directly reduces the HPA axis activity responsible for cortisol production. 5 cycles of this pattern before sleep takes less than 3 minutes and has documented effects on heart rate variability, a proxy measure of autonomic balance that translate to measurable reductions in nocturnal cortisol. This is not relaxation theater. It's a specific neurological input with a documented hormonal output. Sleeping in a room maintained between 18 and 20 degrees C, roughly 64 to 68 Fahrenheit, supports